Baedorf Kassis, also from Boston. We've designed a session that's supposed to be interactive. So please, everybody feel free to answer questions or to bring up questions as we go through 3 or 4 case studies in Dyssynchrony on the ventilator in the ICU. So can we advance the slide? You have it. Okay, great.
All right, so we designed this session because I think Dyssynchrony is one of those topics which is both incredibly common, but also oftentimes either ignored or misunderstood in a lot of ICUs. And there's a lot of variability in terms of how people treat it, and actually I think a lot of misunderstandings about how to sort of identify it at the bedside. So the first case we're going to talk about is a very common form of Dyssynchrony. This is a 39-year-old patient who was admitted to the ICU for ARDS. They're on lung protective ventilation strategies. They're weaning the FiO2 and PEEP and decreasing sedation as well. And you get called to the bedside for this irregular breathing pattern. And it's supposed to play. Here we go. Here you can see these 2 breaths that are stacked one after another. And these, what you can see here is that the ventilator delivers the first breath and then actually artificially re-zeros the volume before the next breath as well. And so anyone in the audience have any ideas about what we're seeing here? I kind of hear a little...
Yeah, you have to speak a little.
Murmuring and mumbling. Double triggering, exactly. All right. And one of the things we wanted to point out here is that the ventilator, and all ventilators really do a very poor job of identifying this because of the fact that it re-zeros the volume. So any breath stacking event can be really more challenging to see than oftentimes we expect because of that.
So just wonder, why wasn't it flow starvation that he gets a too small tidal volume?
Yeah, so there's a question about flow starvation, and this is actually, we're going to be talking about that as well. There's a lot of overlap between patients who are having double triggering because this is one of the high drive forms of Dyssynchrony. And so flow asynchrony or flow starvation is common as well as other forms of sort of high drive Dyssynchrony with this. And actually, you're beating us to the punch here a little bit, so very good job.
So you can see here the double triggering, and if you look at this volume curve, this is not corrected. Yeah, sure. So this is not corrected. This doesn't re-zero between the breaths, and you can see very well the breath stacking. So even though it doesn't look like you're getting injurious volumes here, this type of Dyssynchrony can be very injurious to the lung because you can easily get, and this is another example, you can see the first breath and then the second breath stacks. So this is a physiologic recording that doesn't re-zero like the ventilators do. And you know why the ventilators do that, I'm sure there's a good reason, but it can be extremely misleading in this form.
Yeah, so we those waveforms are from just by integrating the flow. And by integrating the flow, you're able to see the total volume that's delivered through that complete breath stacking event. And so when we're thinking about this, we have a number of different questions. So what when you all see this, we already had someone already make a nice comment about flow hunger or flow starvation. What other things are you all thinking about when we see this? You can sort of call things out if you want to, or we can talk too. And then how do you recognize this Dyssynchrony at the bedside? And as you can see here, the best way to do it is to really see these couplings. And actually you can even see double triggering is sometimes often misnamed because sometimes it's actually triple triggering in some cases if patients have large enough efforts. And so you see these groups of breaths that are grouped together. But the important thing, and we'll talk about this for differentiation, but with reverse triggering, is that this is a patient-initiated initial breath. So patients initiate the first breath and then have either persistent activity or enough consistent activity that extends beyond the initial breath to then trigger an additional breath as well. Okay?
So how would people generally approach this? What would you do when you see a patient doing this? sorry, yeah. Sorry.
Okay, so yeah, so sedation is one of the key factors, absolutely, and we'll get into that in a moment as well. Anything that we can do on the ventilator itself? What's that? Yeah, so this is a discordance oftentimes between what the patient's desired inspiratory time is and what's set on the ventilator. And in some cases, you can adjust the inspiratory time to actually match what the patient wants. Oftentimes, though, the patient's drive is so high that we're not unable to really do that. But matching the patients with higher levels of support on the ventilator, increasing PEEP, increasing the minute ventilation. In some cases, this may help patients. In other cases, though, this may be insufficient to actually match what the patient's high drive is. And if that's the case, then increasing sedation may be needed in these cases as well.
But it's worth pointing out that increasing sedation won't always do the job here. So it can go the other way as well.
Yep. And then this was already kind of discussed by this gentleman in the front here, but this is one of these forms of dyssynchrony that oftentimes you see in combination with other forms of dyssynchrony, which we'll talk about in a little bit as well. These sort of high drive dyssynchrony states, these flow starvation states, okay? All right, and we're showing this one as a contrast, okay, to the prior one. So this is a 48-year-old gentleman with COVID ARDS, is deeply sedated with a RASS of -5, and you're called to the bedside for the following, okay? And so here you can see, unlike in the prior case, this patient is actually not triggering each breath themselves, all right? These are ventilator-triggered breaths. And interspersed in there, you can see that there is one of these coupling events here where you see breath stacking. You can see the re-zeroing of the volume. And then there's a number of other breaths where you don't see that, but you see some abnormalities in the pressure tracing, in the volume tracing, and then the flow tracing as well. All right, and before we say what this is, does anyone in the audience have any ideas about what kind of dyssynchrony this might be? Do I hear reverse triggering out there? Very good, very good. All right, and this is important because reverse triggering and double triggering both can cause breath stacking events, okay? And it's really, really important to differentiate the two from each other.
And the fact that the ventilator breath comes first here is really sort of pathognomonic to identifying reverse triggering.
And so, again, we already talked about this, but this idea about breath stacking is that the ventilator, again, really sort of underestimates what the volumes are being delivered here. And this is another case of reverse triggering. You can see each of these breaths are ventilator-triggered breaths, not patient-triggered breaths. And then in this particular case, this patient was having runs of this at about I forget if it was a 6-to-1 ratio, but continued runs of intermittent reverse triggering doubles triggered breaths as well, okay?
It's worth looking here. This is the esophageal pressure, so the pressure in the thorax. And you can see this huge negative deflection as the diaphragm contracts. Now, people are familiar with the concept of transpulmonary pressure. Can you go back just?
Oh, sorry.
Yeah. So he's rushing me along here.
Sorry about that.
So if you actually calculate the transpulmonary pressure, you have a stacked positive breath on top of a negative inflection in the chest wall. And the transpulmonary pressure, the pressure in the lung, is going to be massive. So you're at risk here not only for high tidal volumes, but high pressure on the lung as these breaths stack.
Yeah, and you can see on the bottom, the transpulmonary curve, you can see the pressure. Those pressures get massively higher than what you get with the corresponding passive breaths, right? These are really large stresses across the lung, which if delivered with enough frequency, may really put the patient at risk for overdistension injury in some cases.
And it's hard to see the scale on those tracings, but it was getting to a transpulmonary pressure of 30. Anything above 12 or 15 is probably injurious. So it was massive pressure directly on the lung.
And I'm sorry, it keeps on flipping ahead without me actually doing it. I'm not sure why, so I apologize if I accidentally. So in this case here, we're trying to differentiate between the two flavors of breath stacking, right? So we already talked about double triggering, and then we talked about reverse triggering. And so the key differentiation point here is what we're seeing here, right? This is a ventilator-triggered breath initially. This is a patient-triggered breath initially, okay? And if you maybe some of your centers have esophageal manometry. I'm not sure if you guys are familiar with esophageal manometry. When you do have that, it does make it a lot easier to actually differentiate. And the way you can see that is that you can see that the esophageal pressure dips here in response to the patient triggering the breath here. And then actually here you can see that when the esophageal pressure actually increases with the reverse trigger breath, which is consistent with a fully passive chest wall initially, and then subsequent diaphragm contraction and reverse triggered initiation. I also will point out here, because of the overlap in double triggering with other forms of high drive dyssynchrony, those blue arrows actually show expiratory efforts. So the patient has a big double trigger event and then actually bears down again. You can see the esophageal pressure actually increasing as the patient engages their abdominal muscles to try to force that air out, and then takes another double trigger event. So it does this a couple times. So you can see sort of other elements potentially of high drive in there as well. Again, sorry, I apologize. It kind of just switched ahead on me for no reason. I'm not sure why. So here we can see the two side by side again to help differentiate. So here we see in the right panel the patient initiating, triggering the breaths themselves, and on the left panel the ventilator triggering the breaths.
And notice that in both types you won't see the breath stacking on the volume curve because of that zeroing issue.
And so in terms of reverse triggering treatment, this is an ongoing subject of a lot of debate, and there isn't really a great answer for this. The overall treatment strategy that we do is first adjust the ventilator, and then after adjusting the ventilator, we touch adjust the sedation. All right, so reverse triggering is oftentimes in opposition of double triggering, something that actually gets better if you lower the sedation, but not always though, because there's different forms of reverse triggering. Some forms of reverse triggering actually don't always respond in that sort of way. But what we can do in some cases is this may still be the same response that we see to the patients inherently wanting more. And so there's suggestions that increasing tidal volumes in some cases, if safe, can address reverse triggering. Increasing PEEP, again, if safe, can sort of satisfy the stretch receptors of the lung through the Herring-Breuer reflex. That all of these things, if you sort of satisfy the lungs, provide a little more support, may in some cases also help improve reverse triggering. The truth is, though, is there are some forms of reverse triggering, which we'll talk about next, which we may not always need to be quite as worried about too, okay? And so here's that same patient that we were talking about as well, who's having a mixture of reverse triggering events here, which are not actually causing breath stacking events as well, okay? And so this is a really key differentiation too, is that reverse triggering, if it occurs early or at a lower amplitude, or if it doesn't extend into the expiratory phase, then you're not always going to be able to see it by the breath stacking events that occur.
And I'll just put a plug in for the esophageal manometry. Most modern ventilators and most of the ventilators you have in your ICU now can do that. And placing the balloons and following the tracings will really allow you to properly identify these dyssynchronies. In my past I heard 20 lectures like this and never got anything out of it. But when we started looking at the esophageal tracings, it becomes instantly clear. So even if you don't use it to clinically treat your patients as a diagnostic tool, and it's as hard as placing an NG tube, it's a great tool for bedside identification of dyssynchrony. The ventilators don't do it well. It's possible to automate that. Ventilator companies are working on it, but for the meantime, adding in that esophageal manometry will really help you.
And so when we're looking at breath stacking, breath stacking events are much easier to differentiate, I think, than reverse triggering when they're not seeing breath stacking. And so we'll talk about next a little bit of how do we actually identify at the bedside reverse triggering when there's no actual breath stacking events, because this can be a little more challenging. Okay, and so first, what is reverse triggering? This is also, there's probably multiple different forms of it. What I'm showing you here is classic reverse triggering, where we see that this is esophageal pressure in the top, and with what you see is that the ventilator delivers a breath, and in response, there's a neuromechanical coupling of the diaphragm contraction with the ventilator delivered breath. And this is very tightly coupled in this particular patient, Because as you can see, during the breath holds, both inspiratory and expiratory breath holds, the coupling creates no additional diaphragm contraction during those times. If you waited long enough, the patient would start resuming inspiratory activity. But you can see in the moment here, there's very tight coupling. And this is the classic form of reverse triggering, which is due to that entrainment of the inspiratory muscles with the ventilator, okay? And so there's different sort of explanations that people have hypothesized. People have hypothesized that this is sort of a physiological response to locomotion. So if we're walking along, right, we mechanically optimize our breathing with our lungs, and this is seen in bipedal species as well as quadrupedal species at different ratios. And it's we all do this probably without even thinking about it as we are running, walking, and even if you've ever done a demonstration of putting yourself on the ventilator, we may sort of actually make it easier to deliver that breath by unconsciously coupling our breath to the ventilator itself. And in a pathologic state, where you see this discordance between a tightly coupled and tightly coordinated activity to a discoordinated activity that may be sort of a little bit more removed and delayed from the actual delivery of the breath. And so the reason why I'm showing this slide is just because the reverse triggering can cause different effects. You can see again these large volumes that are, this is a patient who's in a pressure regulated volume control mode, and this is a patient who's getting much larger breaths with the reverse trigger breaths. Even though they're not causing breath stacking, the actual size of the breath is much larger. And then similarly, you can see that the transpulmonary pressures are also much larger with the reverse triggering breath. But this is not causing any breath stacking event in this case. And because of the timing of the reverse triggering during the inspiratory phase, it's much harder for it to actually be visualized than it is in the late stage. So here we have reverse triggering during expiration, and this is much easier to see, I think, than during the inspiratory phase. And the reason why is because you have a couple clear signs. Even if you don't have the transpulmonary pressure or the esophageal pressure, you can see the changes in the flow tracing during exhalation, and this, what I call like a knee in the volume, where you almost have a slowing down of the exhalation. And you can see on the waveform here, the patient breathing, that the flow actually is completely stopped during exhalation. That's how strong that reverse triggered contraction actually is. And if it was a little bit stronger, or maybe a little bit sort of different timing, that might actually be strong enough to actually trigger a stacked breath too. But in this case, it's just right below that threshold. And so reverse triggering during exhalation can be much easier to detect than during inspiration.
How can you differentiate from the mistickling?
How can I differentiate it from what?
Mistickling.
From mistriggering, yeah. So it's a great question. So obviously during exhalation, it seems like this could also be a mistriggering event. It's the coordinated, tight coupling of the activity. It's the regularity of it. And so the mistriggering is oftentimes not. You're not going to see it with this regularity. Mistriggering is a sort of active breathing process, and you'll typically see it with much more spontaneous breathing efforts as well. So if you're seeing this without any other spontaneous efforts, and you're seeing consistent ventilator-triggered breaths initially, then it's unlikely that this is mistriggering sort of in the classic sense from a spontaneously breathing patient who's just not able to trigger the ventilator with enough.
And you can see it here. It's essentially completely regular, right? So.
All right. So in terms of I think we should probably move on. Reverse triggering is a very, very complicated form of dyssynchrony, and the truth is we don't know yet how dangerous it actually is. I think my personal belief is that if it's occurring in a very sick patient who's having frequent breath stacking events, we treat this the same way as we treat any sort of overdistension risk for injury. And similarly, if we see even the reverse triggering that's not causing breath stacking and a patient is very sick, we worry about sort of self-induced lung injury as well as diaphragm injury as well from that sort of the eccentric contractions that occur. So my personal belief is that we probably can ignore it in less sick patients and then really, really suppress it in our sickest of patients to prevent lung injury. But the truth is we don't really know yet about the how injurious reverse triggering actually is, and it's probably variable, like so many other things, depending on the individual patient.
So do you want to skip to the next case, or
Sure.
continue?
So this is just continuing this idea, and we actually already had a gentleman here kind of predict this, but this is another form of high drive dyssynchrony, and so the patient is being weaned now to pressure support, and now you're seeing these big dips during inspiration here on the top, where the patient is trying to get more flow than what's being delivered. Okay, and this is this idea of flow hunger or flow dyssynchrony. And flow hunger, flow dyssynchrony is especially bad in volume control settings when the flow is a fixed flow. And if the patient wants a flow pattern or flow rate that is different than what is being set on the ventilator, then the patient is going to show the evidence of this flow hunger potentially.
And this is usually going to be coupled with a patient's appearance. So you're going to see a patient really struggling on the ventilator as they try to suck air through the straw of the endotracheal tube.
Yeah, and that's a very excellent point, Danny, because we're looking at waveforms and talking about, but we're not actually talking about the bedside evaluation of the patient. And these are often those patients who are going to be showing other evidence of it too: nasal flaring, jaw thrusting, potential other accessory muscle use as well as part of the exam. That's going to indicate that these are patients who are at high risk. And so in terms of treating flow asynchrony, obviously a lot of this is just delivering more support, more flow for a patient, making other adjustments to sort of support the patient with more total support. There's evidence that potentially some of these hybrid modes, like pressure regulated volume targeted modes, may decrease it because it doesn't force the patient to be in a specific flow pattern. And the risk for flow asynchrony is not totally defined yet, but we think that most likely it's because of if these are patients who are taking really high, who are exhibiting really high drive, that they could be injuring their own lungs through self-induced lung injury as well. And so this is one of the ones that, again, we don't definitively know how injurious it is, but I get very worried about my patients when I see them with this. And in some cases, we need to actually more deeply sedate them if we're unable to approach the dyssynchrony on the ventilator itself.
But I think to Elias's point, and probably the point of the whole session, is think about the dyssynchronies, try to type them, and then try to treat them with the ventilator rather than reaching for the sedative right away. And I'm sure all of you have been in that scenario where you come in the morning and they tell you the patient was fighting the ventilator, so we cranked up the propofol, or we started neuromuscular blockade to get them in sync. And really what they probably needed was better attention to the ventilator itself. Yeah.
Please.
Do you not get worried with the previous case, the fast pulmonary pressure?
Yes. So what we're not showing here is the esophageal pressures, and your point is very well taken, is that these are absolutely concerned. So the total pressures that are being delivered potentially may be much higher than what we're actually seeing because of the diaphragm contraction. If I actually showed you the waveforms for it, it actually wouldn't be as impressively bad as you might expect, though. The reason why is because if the patient is having a big inspiratory effort, the airway pressure is often going to be sucked down as well. And recall that the transpulmonary pressure is the airway pressure minus the pleural pressure. So if you have a big drop in your pleural pressure, you may see the sucking of the airway pressure too, which means that the pressure across the lungs, the transpulmonary pressure, may not be quite as bad as you might expect. However, it's still going to be magnified because of those high efforts also, not just descending the lungs itself, but also trying to draw pressure down the airways too. So you will have a magnification of transpulmonary pressures through flow asynchrony, but it may not be quite as bad as you might expect with this. But what you will see is the heterogeneity of the lungs means that the stress is not going to be distributed evenly, and so you're going to get locally much higher stress on the lungs. And so that's why the mechanism of lung injury is multifactorial from this.
And the sicker the patient, the less evenly it's distributed. So if you have a patient who's already with ARDS, the consolidations associated with that are going to really change the mechanics of the transpulmonary pressure to exacerbate the injury in those consolidated areas.
Yeah, it's a very good point. Yeah, and the stress razors of the lungs as well, sort of the classic modeling of the coupling of of the injured areas, the non-injured areas, is going to magnify those stresses even further as well. Okay, so this is a 65-year-old different case. A 65-year-old man with smoking and COPD. They're intubated, it's started antibiotics and steroids, and there's ongoing accessory muscle use, prominent abdominal contractions, and we see these peaked airway pressures here. Okay, the patient's on volume control, the PEEP of 5 centimeters of water for this. So a lot of people are going to look at this and say, oh, I see scooping of the airway pressures here. This looks a lot like other demonstrations of flow asynchrony that I've seen before. All right, but does anyone in the audience have any idea what we're actually seeing here with those peak pressures? Call it out if anyone has any ideas. What's that? So yeah, so exactly. So we're seeing a patient who's having expiratory muscle activity terminating the inspiratory phase. So this is a form of expiratory muscle activity that is actually that's causing dyssynchrony of the ventilator, where the set inspiratory time on the ventilator may be longer than what the patient actually desires. Okay, and so in this case, the patient is going to so it's not going to overshift though beyond what the total. You may see a little bit of a pressure like that, but if you're seeing a pressure that's significantly higher than what the total pressure that's being applied in the ventilator is, then that you would not expect to see a very, very high pressure. But you're right. In some cases, you may see that sort of relaxation phase too, causing a little bit. Yeah. Yeah, and I'll show you on the next slide how that it's important to actually incorporate the clinical exam on the bedside too. So if you see the patient actually having a Valsalva with each breath, bearing down, the sort of thoracoabdominal discordance, not just simple relaxation, but also actual engagement of the expiratory muscles, then that's a good way of differentiating that phenomenon from this actual expiratory muscle activity.
Pull that out. Okay.
So I'll actually skip ahead to, here we go. And so, what I always teach our fellows and residents is to go, when we go to the bedside, put one hand on the chest and one hand on the abdomen, and feel what the abdomen is doing during the expiratory phase. And you can feel the abdominal muscles in patients who are having this frequently actually engaging and contracting in response to the inspiratory phase to actually terminate that. And this is actually a fairly minor example of it. In some cases, you can see that it's actually quite dramatic. But it's the other way is, let's say I have a patient who's on pressure control or pressure support of 5/10, right? And my peak pressure is 25. That is a significantly higher peak pressure than what is being set on the ventilator, and that's an important differentiation from flow asynchrony, where you'll actually see that the pressures are lower than what's expected. And so what we're showing here is that expiratory efforts are not always just terminating the breath. They're also sometimes actually even more concerning, where the patient's actually bearing down against the ventilator over a longer period of time. And so if I look on the ventilator here in the bottom tracing on the left, you can see that the volume actually kind of dips down to 0, and then actually you don't see it extend any further. And why that's doing that is the ventilator is re-zeroing again. So you're missing the fact on the ventilator that the patient is actually exhaling to a much lower total lung volume by bearing down because of that re-zeroing effect.
And you can see that nicely here as the volume decreases as they continue to push against the ventilator.
Yeah, so the tracing on the right is by integrating the flow again, you can see that the total volume actually decreases with each delivered breath. And the patient may obviously, the concerns of this are what is this doing to the patient's recruitment? Is the patient de-recruiting? Are they setting themselves up for adolect trauma? And we have, we've seen patients who are doing this repetitively over and over and over and over again, where they're bearing down, they breathe, bear down, breathe, and they'll do this over multiple different breaths. And it's actually, I think it's unfortunately more common than we realize too, but we're not always looking for it. And I think actually expiratory activity is one of those areas that remains a little bit of an unknown and a black box in our intensive care community. There's some folks who are doing some great research on it, but the actual effects of it, I think, are not really still that well understood. And it's probably both more common and also more injurious than we realize. Even though we see it in 50% of patients with COPD have some expiratory muscle engagement as part of their sort of daily existence to help augment, or they try to augment their flow, maybe unsuccessfully. Okay, so now the patient is weaned to pressure support. They're on a PEEP of 5 with the FiO 2.4. The pressure support is at 10 centimeters of water, and the trigger sensitivity is 2. Okay, the patient though is restless and uncomfortable, and during an expiratory breath hold, the patient has a total PEEP that's measured of 12 centimeters of water. All right, this one is not. This one is a little bit easier, I think, than some of the other ones. Anyone kind of call it out? I think I heard someone said mistriggering out there. Yep. So you can see here that we have mistriggered events where the patient is trying to take an effort, trying to take a breath, but the ventilator is not delivering any volume in response to the patient's attempted inspiratory efforts.
So how would we treat this?
Yes, exactly. So I heard raise the PEEP or change the sensitivity. Those are what we do on the ventilator. But we also want to treat the patient, maybe help improve bronchodilation. If they're not on steroids, give them steroids, albuterol, et cetera, to help open up the airways and decrease the resistance as well.
So I think we're at the end of the time. Do you want to just show the
sure.
PEEP slide?
Yeah.
Yeah.
So if we're at the end of our time, I think what we'll finally say is that the idea of how do we respond to mistriggering is by, as someone said, adjust the PEEP. And the rationale for that is that if somebody has a total PEEP of 12 centimeters of water, for example, then you have to overcome the auto PEEP and the trigger sensitivity before you're actually able to trigger the ventilator. And so if you adjust the PEEP to match the degree of auto PEEP, then you make the total amount of pressure that the patient needs to generate much, much less in order to trigger the ventilator. And it can make it much easier for the patient, make them much less uncomfortable. So I think we're at the end of our time. Is that right?
Yeah, we are. So
Okay.
I'd like to thank you all for coming. The slides are going to be available on the conference website, so people can take a look at them at their own time. And I think they'll be very helpful when you go back to help teach your other staff on this topic. And I would, last plug, try the esophageal manometry. It will really help you understand this. Thank you all.
Questions up here offline too.